Okay, so this is a lecture on acid-base balance by Dr. Muhammad Abdi himself, the king of metabolics.
Acid-base, yeah?
Okay.
First definition of an acid.
Okay.
Acid is a substance that ionizes in water to release H+.
Okay.
Yeah?
Yeah.
So what kind of acid do we produce? The commonest acid that we produce in our body is carbonic acid, H2CO3. Yeah?
Yeah.
From when CO2 mixes water to make H2CO3.
Yeah.
Other acids that we produce in our body are non-organic and organic acid. Non-organic are things like sulfuric acid, will break down of amino acids such as cysteine or sulfur.
Okay.
Yeah? And secondly, organic acid, which is incomplete oxidation with the carbohydrates.
Okay.
So why is it important to know about acid?
I think before we go on to that, Muhammad, you've forgotten to mention one little thing. You've defined what an acid is. You haven't defined what a base is. So if you're saying that an acid is a substance that ionizes in water to release hydrogen ions, I think it's important to also mention that a base is a substance that combines with hydrogen ions.
Yes.
Okay, brilliant.
Okay. Importance of an acid base. Why is it important that we're talking about? Because it's important that our body keeps, we balance the acid base within our body. The reason being because acid pH is an important factor in our body in transmembrane potential.
Okay.
In formation of active potential, exciting the electroactivity in the heart, calcium dependent, and also to on albumin. Albumin is very bound to calcium, and in acidosis we know that calcium will be dissociated from albumin, and H+ will bind there. So
Okay.
in acidosis, what would happen? You'd have hypercalcemia.
Okay, and the reason for that is the albumin always has to have it always has to be in a neutral state.
Yeah.
So it's got a lot of cations on it,
Yeah.
and it has to be neutralized by the anion. So it's either
Yes.
calcium or hydrogen.
Yeah.
Now the albumin doesn't mind which one of the two it takes up.
Yeah.
However, when you're in an acidotic state, there's going to be more H+ free to bind to the albumin. Bind to the albumin, that's going to kick off the calcium from the albumin,
Yeah.
And it's going to be an exchange system.
I see.
Okay,
Exactly.
brilliant.
And the thing is, other factors that are important is it's been shown in studies that myocardial contraction can be inhibited by change in pH. In a study done by Steenberg et al., it was shown that a pH change between pH of 7.40 to pH of 6.060, the ventricular pressures decreased by 80%, hence the ventricular contractility was decreased by 80%, hence it's a negative inotrope, hence blood flow perfusion decreases, hence that's a problem.
Okay, brilliant. So that's a negative inotropic effect.
We know also the pH does affect the enzyme activity in our body. A majority of our body is run by the enzymes. We know the pH, the enzyme is normally pH dependent. The other factors that it's been shown in studies that patients who are alkalotic, alkalosis prevents alveoli fluid reabsorption into the lungs, and the problem is the more fluid that stays in the alveoli, the more likely they can become into pulmonary edema.
Okay, brilliant. Let's move on to what pH is.
So, what is pH? pH, as we know in chemistry, is the log of H+ concentration, and that is proportional to PCO2 bicarbonate ions.
Okay,
Yeah?
brilliant.
Yeah. So if we know that increase in CO2 would increase H+, and increase of HCO3 will decrease H+.
Okay, brilliant.
Concentration decrease in pH. Yeah. Increase in pH.
Mm-hmm.
So now we'll
And that's
move
directly
on.
proportional.
Yeah. Now we'll move on to the compensation, the buffer system. The commonest buffer system, which I did not mention, is a buffer system of CO2 plus water, yeah, forming carbonic acid. That's an important buffer system in our body. Other buffer systems that are important in our body is things like proteins such as albumin and hemoglobin are important, and bone is a buffer system. So how do we compensate? How do we compensate and maintain a good acid-base balance within our body? There's two main organs, one the kidney, one the lungs.
Okay.
Kidney, the way we do that is two ways. One the PCT, one the DCT.
Okay.
The PCT reabsorbs HCO3. What happens in the renal tubular, you tends to excrete as much proteins, as much bicarbonate to try and lose out. The body is in demand of as much as bicarbonate, so you will try and reabsorb majority of the bicarbonate.
But you can't absorb the bicarbonate because it's non-soluble.
Exactly. So you can't absorb it directly. The only way you can absorb it directly, you have to absorb it indirectly by mixing with the H+. So the H plus is produced by the proximal convoluted tubular cells, H+, which joins up with the bicarbonates in the tubules, which then becomes bicarbonic acid, which then transferred to become CO2, which is then reabsorbed solely. It's a soluble.
So the
When
CO2 is reabsorbed.
CO2 goes into the PCT cells.
Okay.
The PCT cell then it starts breaking down into bicarbonic acid, and then
Again, using carbonic anhydrase.
yeah, and then dissociates into HCO3.
Okay.
Yeah, and HCO3 goes back to the capillaries, and H plus is reused to reabsorb more.
Okay, brilliant. I'd just like to comment on this being the most terrible diagram I've ever seen, but carry on.
I'm not good at it. That's why I'm black. Okay, and the other part is distal convoluted tubule, where you have excretion of H plus.
Okay, brilliant. So the primary convoluted tubule is to do with reabsorption of bicarbonate ions, and the distal convoluted tubule is to do with excretion. So just, I suppose, dump. Okay, never mind. Dump excretion. Yeah.
Yeah, excretion, dump, and the other one is
P for pull. Pull.
Yeah.
Okay,
so
reabsorb.
it pulls all the bicarbonate. Okay.
Lungs.
The lungs.
Very
the way
simple,
we
doesn't
maintain
need much explanation.
CO2. We know that in CO2, the carotid body and the aortic body sense the changes in CO2, and what happens? They increase respiratory muscles and cause you to hyperventilate and try to excrete
brilliant.
CO2. Yeah.
Respiration. No, sorry.
So
abnormalities.
So abnormality of acid base can be divided into alkalosis or acidosis. So let's start with alkalosis, which is much more simple. Alkalosis, we can divide it into respiratory and metabolic. Respiratory part is due to mainly decrease in CO2, and the way we can decrease CO2 is by hyperventilation. So people who are anxious would hyperventilate, people on high altitude would hyperventilate, and also primary hyperventilation syndrome, Aziz's favorite syndrome.
My favorite.
Yes.
No,
And the compensatory for patients who are hyperventilatory syndrome, it would be compensated by the metabolic, which is in the kidney. So in the PCT, what would happen? In the PCT, you would be stop absorbing.
Stop reabsorption of bicarbonate. In the DCT, it'd be excretion of hydrogen ions.
Prevention of excretion of
Okay,
hydrogen.
brilliant.
Yeah, so that's the way.
Let's move on to metabolic alkalosis.
Metabolic alkalosis is due to loss of H plus, and the way it's difficult to maintain metabolic alkalosis. We know that the best way to generate, you can generate metabolic alkalosis through loss of H plus, or decrease ECF, or gain of an alkaline.
Okay.
And that's the two main methods. However, the body is clever that it's very difficult to maintain metabolic alkalosis through this mechanism, the PCT. The PCT will stop reabsorbing bicarbonate. So what would happen? You cannot maintain metabolic alkalosis.
Okay.
So you need another. Not only you need loss of H plus, you need another mechanism to maintain. And another mechanism could either be the decrease of ESL, extracellular fluid, or gain an alkaline. The way, as an example, in vomiting, you'll be losing H plus from your stomach, but you also be losing fluid, so you lose extracellular fluid. So one of the causes is in metabolic alkalosis is vomiting.
Okay, brilliant.
Or diuretic therapy. Yeah. How do you compensate? Lungs.
Okay, brilliant. Let's move on to acidosis.
Acidosis. So in acidosis, the cause
Start respiratory. Nice and easy.
Respiratory is due to increased CO2, and the increased CO2 is failure to excrete CO2 in our lungs. Causes are lung disease such as asthma, COPD, clots in the lungs such as pulmonary embolism, which are common. And then we've got, we can look at the formula, is increased CO2 will increase H+, which is, and hence you become more acidotic. Compensation through the kidney, the PCT, through what? The compensation of the PCT will, in acidosis, trying to reabsorb as much as bicarbonate as you want, and DCT to enhance excretion of H+. Yeah?
Okay, brilliant.
And then you got acidosis, metabolic acidosis, which is due to failure to excrete.
All right, before you start, I think it's important to make a quick point that when it comes to respiratory acidosis and alkalosis, the only compensation you have available is metabolic. However, when it comes to metabolic acidosis or alkalosis, you've got the two types of compensations available. So you've got metabolic compensation as well as respiratory compensation.
Where
in when it comes to metabolic